Good morning. This week's work will be centered around visceral disorders and laboratory interpretation of diseases with the symptom dyspnea. As always, we will look at the learning outcomes at the end of these 5 hours of lecture material. You should be able to define the term dyspnea. You should be able to list the various diagnostic triads, describe the key features of each of these diseases covered in the diagnostic triads, review the labs mentioned, and review the significance of the physical signs mentioned in this discussion. Our index patient today is Flo. Flo Sicalot is the youngest of the 3 girls, whose parents are Brian and Maria. Flo has a problem with shortness of breath, otherwise known as dyspnea. Dyspnea is defined as the unpleasant subjective sensation of discomfort or difficulty in breathing. Flo presented suddenly early one morning, woke her up from sleeping with shortness of breath and audible wheezing, and the parents rushed her off to the ER. Now, what are some of the generators of dyspnea, otherwise known as shortness of breath? First, it could be in the region of the lung, pulmonary causes of dyspnea. We're going to do many of these. Asthma would be one in a child, pneumonia would be one in the adult. 2, it could be a problem with the heart failure, could cause shortness of breath. 3, it could be a brain stem problem where respiration is controlled primarily in the medulla oblongata with some secondary influence from the pons. And 2 causes here would be compression of the brainstem due to raised intracranial pressure or diabetic ketoacidosis. And then the 4th level at which dyspnea could be generated would be in the higher cortical centers, primarily in the hypothalamus or in the cerebrum of the cerebral cortex in particular. And panic attacks would be a good example of this type of generator of shortness of breath. Any questions? Remember, pathophysiology is not the focus of these lectures, but I will mention the pathophysiology as we go along as a way of helping you to understand how might the shortness of breath breathing pattern be different from a patient with asthma or pneumonia or diabetic ketoacidosis or panic attack or cardiac failure. Okay. All right, so let's look at the first red flag triad. This is the red flag in which shortness of breath, aka dyspnea, is associated with chest pain. The first of these red flag situations is pulmonary embolism. Pulmonary embolism is defined as a blood clot in the lung. And I know that there are 4 types of embolism, and blood clots would be one of them. Others would include air embolism, fat embolism, or rarely amniotic fluid embolism, but 98% of all pulmonary emboli are associated with DVTs. DVTs, deep vein thrombosis, you have a clot in the leg or the pelvis, a piece of that clot breaks off, goes up into the inferior vena cava, right atrium, right ventricle gets stuck somewhere in one of the main or smaller branches of the pulmonary arteries. So, causes, As I said, 98% of pulmonary emboli are DVT related, and the DVTs are going to be one of these three main factors that are universally grouped together as Virchow's triad: oral contraception, antidepressants, which would increase hypercoagulability, leg injury, which causes damage to the vascular endothelium, and that will trigger the formation of a clot. Or it could be stasis due to either a long recent travel by air or by bus. And by long, I mean anything greater than 4 hours in which you didn't get up of your seat and walk around, or you had to be immobilized because of a fractured femur, or you were in hospital for a serious condition and was in bed for more than 4 hours at a stretch, not moving. The classic clinical picture is a triad, and that triad is made up of sudden onset of shortness of breath, hemoptysis, which is another word for coughing up bright red blood in the sputum, and pleuritic pain. Pleuritic pain means there is chest pain. The pain is precise, it is sharp, well localized, and if you were to look at what the patient's hands are doing, when you ask them, show me where the pain is, they will probably take their index finger and point to a precise area in the anterior or posterior chest to say the pain is right here. And if I take a deep breath or I cough or sneeze, the pain is worse. So all of this is encompassed in the one word pleuritic: sharp, sticking pain made worse with deep breathing, coughing, or sneezing. If you suspect pulmonary embolism in a patient, call 911. When they get to the hospital in the ER, they would arrange for either a spiral CT scan or a ventilation perfusion scan, a lung scan known as a VQ scan. Now, the difference between these two, the spiral CT scan, you do not give the patient anything intravenously or to swallow. You just put them in the CT tube. The scanner donut goes around the patient, takes several hundreds of pictures, and thus is a non-invasive test. The ventilation perfusion scan involves the injection of a radioactive dye and then taking a picture with a special gamma camera looking for equal distribution of the dye in both lungs. And if there is a defect in one of the lungs, then this is indicative of a blockage of the blood supply to that wedge-shaped portion of the lungs. The D dimer, which is also ordered at the same time, because it has a very high sensitivity and not a very high specificity. If the D dimer test is negative, you can comfortably rule out the possibility of a pulmonary embolus caused by a deep vein thrombosis. Just to remind you, D dimer is a fragment of a blood clot. And if this fragment of a blood clot is not present in the blood, it tells you beyond the shadow of a doubt, within a 5% error, that there is no blood clot. And if there is no evidence of a blood clot, then this can't be pulmonary embolism caused by a DVT. If they were to order an X-ray, you would see this particular, and I would use the pointer here. Over here in the right lung, out in the periphery of the mid zone, there is this wedge shape area, small wedge shape of whiteness or consolidation. That's where the lung has been deprived of blood, and it shows up as this wedge shape hump known as Hampton's hump. Hampton's hump sensitivity is 21%, specificity is 82%, and therefore If it is present, it could indicate the possibility of pulmonary embolism. If it is not present, it means absolutely nothing because the sensitivity is very low. Um, so what I have here is a normal X-ray, which is the one on the left side, and the X-ray that has the Hampton hump on the right side. So you can have a sense of comparison what the Hampton hump looks like. As I said, the X-ray on the left was taken of a patient with shortness of breath, sticking chest pain that was made worse with breathing deep or coughing, and a little bit of hemoptysis. So it was highly suggestive of a pulmonary embolus, but the X-ray was normal. A normal X-ray in a patient suspecting of having a pulmonary embolus is not to be taken as, oh, pulmonary embolism is not present. Another cause of shortness of breath associated with chest pain is pneumothorax. Pneumothorax is defined as air in the pleural cavity. There should be no air in the pleural cavity. There should be a little fluid with a negative intrathoracic pressure to keep the lungs fully expanded. Causes are one, traumatic. So the trauma could be from outside or inside, penetrating trauma from the outside, or a rupture of a emphysematous bleb associated with the patient with emphysema, and the large bleb just ruptures and spills air into the pleural cavity. Or it could be spontaneous, which means it happens just like that with no antecedent trauma or any other pulmonary disease. Clinical picture is classic: sudden onset of shortness of breath, sticking chest pain, and when you percuss over the area where the pneumothorax is, it is going to be very hollow, increased percussion note, and when you put your stethoscope over that area, you are likely not to hear any breath sounds because of the collapsed nature of that particular lung. Labs X-ray will show the collapsed lung, and I'll show you two X-rays shortly. You're looking specifically for where the trachea is. If the trachea is deviated away from the side of the pneumothorax, this is a tension pneumothorax, and this is a 911 call. If you don't have time to do an X-ray, you can confirm that the trachea is deviated by putting your middle finger into the space just above the manubrium of the sternum. And if your trachea is not slap bang underneath your middle finger in the midline, it's off to one side, then the trachea is deviated. If you suspect this is a tension pneumothorax, either by X-ray or by physical examination, this is a 911 call. When the EMT guys get there, they will confirm the diagnosis that this is a tension pneumothorax and attend to it right there and then in the ambulance on the way to the hospital. If just a simple pneumothorax, whether it be a total or partial on one side, is present, send the patient urgently off to the hospital. So here is a picture of a pneumothorax on the left side. So here is the outline of the collapsed lung. It's a total pneumothorax on that one side. Here is air filling the pleural space. Over here you have the faint outlines of the bronchopulmonary markings. That is classic for a fully inflated lung. And then you look here and you can see the spinous processes are in the middle of this air shadow. So this is a straightforward pneumothorax with no tension or deviation of the trachea. Here is one in which the trachea is markedly deviated, pushed over to the left side. Here is the massive. Every time the patient takes a deep breath, more air gets into the pleural cavity and can't get out because there's a one-way valve due to the injury that induced the pneumothorax. And look and see how the entire mediastinum, which should have been somewhere in the middle here, being pushed over to the opposite side. This, as I said, is a 911 call. Next is a panic attack. Panic attacks, for the first time, may be confused with pulmonary embolism, heart attack, or pneumothorax, and therefore this is why it is in here. If this is your first panic attack you're seeing as a doctor, or this is the first panic attack the patient is having, and you're not too sure, am I dealing with a panic attack or something more serious? It would be better to err on the side of caution. Call 911 and have the EMT guys who are trained, once the patient gets into the ambulance with the complaint of shortness of breath and chest pain, there's a protocol they follow. They put up a drip, they put on the chest, 6 chest leads. They have a portable ECG, and they're looking to see, is there evidence of ST elevation, T wave inversion, or pathological Q waves. If not, they're watching this patient, and by that time, they may have had a chance to chat with the patient who is rapidly breathing and thinking he or she is dying. So panic attack is under this first red flag triad. Panic attack is defined as sudden, unprovoked episode of fear. We've actually done panic attack when we looked at a previous problem last week. One of the causes of dizziness is a panic attack, and we had to be able to distinguish it from general anxiety disorder or hyperventilation syndrome. And this is why there's a big red asterisk up at the top saying, not that this is important. The big red asterisk, when I use that here, means we have done this already. I'm just going to review briefly, because the next time you see a big red asterisk, I'm going to go, we've done this already. Go back and review that particular PowerPoint. For the sake of time, we're moving off to the next disease. I remind you that the cause of panic attack is unknown. The clinical picture using the DSM-5 criteria is having 4 out of the following 11 problems, and I've arranged the DSM-5 criteria into 2 C's, 2 D's, 2 F's, 2 N's, 2 S's, and 1 P. Chest pain or choking sensation, 2 C's. Depersonalization versus derealization. This is unreal. This is not happening to me. 2 F's, fear of dying or fear of losing control. 2 N's, nausea or numbness around the mouth, circumoral numbness. 2 S's, sweating or shortness of breath. And 1 P, palpitations. You only need 4 out of the 11 plus sudden onset of fear. As I said before, no labs are necessary. Co-manage with a cognitive behavioral therapist. Any questions? If not, let's go to the next diagnostic hub, which is shortness of breath with fever. This is also a red flag situation. The first of these red flag situations associated with fever and shortness of breath is pneumonia. Pneumonia is defined as a lung infection. It could be bacterial in nature, caused by streptococcus, caused by staphylococcus, caused by Klebsiella, caused by plasma pneumonia, or in the current context we're having here, respiratory syncytial virus, flu, or COVID-19. It could be, as I said, bacterial or viral. It could be fungal, or it could be protozoal in nature, less commonly. The classic picture includes a triad in which you have fever with the shortness of breath, tachycardia, and crackles on auscultation of the affected area of the lung. When you are going to do tactile fremitus or vocal resonance over that area, you will find that the tactile fremitus or vocal resonance is going to be increased. There is also going to be bronchophony, egophony, whispered pectoriliquy, and we'll talk about each of these in a little more detail towards the end of these lectures. But just to remind you, bronchophony is where you put your stethoscope on the patient's chest and you ask them to say 99, 99, 99. And when you get to the area where the pneumonia is and it's consolidated, that 99 would sound like this: 99. Egophony is you ask the patient to say the letter E, E. So you're listening on the right side, the left side, up at the apex of the lung, mid zone, E, E, lower zone, E. And when you get over to, let's say the problem was on the lower right half of the chest posteriorly, that E would sound like A, A. So E would sound like A, like the bleating of goats, and that is egophony. And whispered pectoriliquy, instead of asking the patient to say with a normal voice 99, you say to the patient, whisper 99. And you go 99, 99, 99, 99, 99, 99. So the whispered 99 is going to sound like a normal 99. And then there's going to be a decrease in the pulse oximetry. And the combination of these is going to help you to determine whether a pneumonia is present or not. Labs, if labs were ordered at this particular time, the complete blood count will show the presence of a leukocytosis. If there is an infection, and if the infection is bacterial, obviously it would be increased neutrophilia. If it is a viral infection, increased lymphocytosis. If an X-ray is ordered, you will see the classic wedge-shaped consolidation, especially on the lateral view of the chest X-ray, and we will look at that shortly. Management. Now you have to decide, are you sending this patient to a medical doctor for a course of oral antibiotics over the next couple of days, 5 days to a week, or should this patient be hospitalized? You need to know what the CURB 65 criteria is, and the details of the CURB 65 criteria are found in the Green Book, Chiro Essentials Differential Diagnosis. For the sake of this presentation, I will review with you once, but you have to remember this. CURB 65 is an acronym where the C means confusion. How do you tell whether a patient is confused? You ask them what's their name, where are you, what's today's date, and then ask them about what time of the day is this, and then probably ask them a current event fact. Who is the president of the United States? And if they say to you George Bush, they are confused. So C is for confusion. U is blood urea nitrogen if it is greater than a certain amount, and you wouldn't have access to this, but this is what is included in the CURB 65. So U, urea level elevated. R is for respiratory rate, and if in an adult the respiratory rate is greater than 30 breaths per minute, that is part of the curve 65, that if this is present, you're going to send this patient off to the hospital for them to hospitalize the patient and put the patient on intravenous antibiotics for the first 24 to 48 hours. The B in the curve 65 acronym is for a blood pressure. If the blood pressure is lower than 90/60, this patient is likely to be going into shock, and you want to be able to deal with that if and when it happens. They go into septic shock. And 65 is the age. If the person is 65 years of age or older, older people, the elderly, don't do too well with a pneumonia. They die more than the younger adult with a classic strep or staph pneumonia. So you will get one clinical vignette with enough information in which you're going to be asked which 1 out of 4 or 2 out of 5 statements is correct. And one of the statements would be this patient needs to be hospitalized for the treatment of this condition. So that is pneumonia. Here is what P to A of a patient with a right-sided pneumonia looks like. If you look at the left lung, upper zone normal, middle zone normal, lower zone normal. Over on the right side, upper zone normal, middle zone normal, and the lower zone you have this area of whiteness, and that's an area of consolidation. You can't appreciate the wedge shape of this. As I said, this is only seen in the lateral x-ray. But what I want to show you here, there are 1, 2, 3 dark streaks in this area of consolidation. Those dark streaks are air inside bronchi that are present either in the middle lobe or the lower lobe. You cannot tell looking at A to P or a P to A x-ray. This is a P to A x-ray of the chest, whether this is the middle lobe or the lower lobe, because the two could be superimposed on each other. By the presence of these dark gray streaks, these dark gray streaks are called air bronchograms, and air bronchograms are characteristic of an area in which there is consolidation of the lung tissue. Here is what the lateral x-ray looks like, and definitely you can see the pneumonia is in the lower lobe. It's in the posterior segments of the lower lobe, and this is the wedge-shaped area. Upper lobe is up there. Middle lobe is superimposed on the heart. And then the lower lobe is down at the bottom there. So this is a lower lobe, right lower lobe pneumonia. Sometimes it is not caused by your typical pneumonia agents, which would be Streptococcus pneumonia, Staph aureus, Klebsiella pneumonia. Those are the 3 big classic ones. If it's not caused by those, it is caused by viruses like Mycoplasma pneumonia. It could be caused by COVID-19, SARS-CoV-2 infection, or RSV. These are atypical causes of pneumonia, and atypical causes of pneumonia tend to be bilateral as opposed to unilateral with the typical causes of pneumonia. And you have this, what is called a ground glass appearance, this white fuzzy appearance of both lung fields. This is classic for atypical pneumonia. One of the causes of atypical pneumonia, as I said, is COVID-19 infection. So the definition is a viral infection of the lung. The cause is the coronavirus, SARS-CoV-2. Classic picture: fever, cough, fatigue, shortness of breath, and anosmia and diarrhea and blue COVID toes and fingers and bone pain, and the list goes on and on and on, because as we get longer into this extended pandemic, we're finding out that um, COVID-19 infection could present with uh, early onset of type 1 diabetes in an adult. Labs, you're going to look for tests that are going to show the presence of either the COVID-19 antigen and or the antibody test. Management of patients with COVID-19: rest, rehydration. If they're hospitalized, they're going to be given a number of drugs. Um, how to determine should this patient go off to the hospital? You're going to use the curb 65 rule. Or if they're having trouble breathing and the pulse oximeter reads less than 90, so hypoxia, um, as characterized by low pulse ox reading less than 90, is indicative of a patient needing to go into the hospital if they have acquired COVID-19 lung infection. Another cause of shortness of breath with fever would be tuberculosis. TB is defined as a caseous chronic granulomatous disease, usually of the lungs. Rarely does it get outside of the lungs and affects sometimes the bone, sometimes the lymph nodes in the neck, sometimes the adrenal cortex, and very rarely the ductus deferens. It is caused by the fastidious uh, Mycobacterium tuberculosis, which is airborne in its spread or droplet. Classical picture would be a low-grade fever, chronic cough, hemoptysis, night sweats, unintentional weight loss. And if this has been going on for some time and it has become chronic, and chronic granulomatous infections heal with fibrosis and scarring, you may find the trachea being pulled towards the side with the tuberculosis. This is due to a partial collapse of that portion of the lung, usually the apical region, and there is partial collapse, and that is known as atelectasis, and this kind of atelectasis is called retraction atelectasis as opposed to resorption atelectasis and compression atelectasis, which you learned in trimester 4. Labs would include taking an x-ray, finding the classical findings of consolidation and cavities in the apex of either one lung or both lungs. And remember that the reason that Mycobacterium tuberculosis has a predilection for the apices of the lungs is because it is a strict aerobe, meaning it has to grow, it will only grow in the presence of oxygen. And the apex of the lung has the highest ventilation perfusion ratio. The gold standard is identifying the causative organisms, otherwise known as acid alcohol fast bacilli, AAFB, in the sputum using the Ziehl-Neelsen stain, or if the sputum does not show any Ziehl-Neelsen positive bacilli, then you have to wait for the culture for the presence of the tuberculous bacilli growing in the Lowenstein-Jensen culture. This is CDC regulations. Dr. Badalia has taught you that the gold standard is the quantiferon test. It is the best test for screening purposes but is not the gold standard for diagnosing of TB according to the CDC guidelines, and I'm going off of the CDC guidelines. The sensitivity and specificity for the quantiferon test, sensitivity is 97% and specificity is 94%. If the sensitivity and specificity were 100%, then I would have said this is the gold standard. This will tell you whether there is latent tuberculosis or current tuberculosis. If you find the bacillus in the sputum stained with Zeal-Nielsen or the culture is positive, it is not latent, this is active current TB. The management for a patient with suspected tuberculosis is referred to the Department of Health. Give them a call. They will have a particular protocol following the CDC guidelines as to how to deal with this patient. Do the population a favor and not refer a patient with suspected TB to the hospital. There are sicker patients in the hospital, and should these patients be inadvertently admitted, they're likely to spread the bacilli via the airborne droplet route and then cause sickness to other people in the hospital. So please call the local Department of Health and follow their instructions. Here is what the x-ray of a patient with typical TB looks like. In this particular case, both APCs are affected. The mid zones are not, neither are the lower zones, and both have this white fuzzy appearance, which is consolidation, and both of them have relatively large holes inside the lung tissue, and this is cavitation. So apical consolidation and cavitations are present in this particular picture. In addition to that, the lymph nodes in the hilar region on both sides are involved, and therefore TB could cause hilar lymphadenopathy. And if you were to look at the trachea is kind of in the center with slightly pulled over to the right here, because I guess the consolidation and scarring and fibrosis in the right lung might have been longer than in the left lung in this particular patient. Any questions? The next diagnostic hub is shortness of breath associated with wheezing. First cause of shortness of breath and wheezing, especially in children, is asthma. Asthma is defined as either a chronic or episodic reversible airway disease. To distinguish it from chronic bronchitis and emphysema, which is a chronic irreversible airway disease. The causes of asthma could be environmental allergens like pollen, animal dander, other allergens that are going to be inhaled, or it could be exercise-induced or aspirin-induced. Clinical picture, regardless of the etiology, would be paroxysms of shortness of breath. Remember, the word paroxysms means sudden onset of shortness of breath, dyspnea with wheezing, and when you listen to the chest on both sides, there's bilateral generalized rhonchi, which is a high-pitched musical note that is heard best on expiration in patients with asthma. Management of a child with asthma, call 911 if these are present. Cyanosis. And the cyanosis that will be seen in asthma is central cyanosis. And in central cyanosis, not only are the lips and the tongue blue, but if you look at the fingers and the toes, they are also blue. Please remember that in central cyanosis, both the tongue and the lips and the fingers and the toes are all blue. In peripheral cyanosis, only the fingertips and the tips of the toe are blue, not the lips and the tongue. So if there is cyanosis, it's a central cyanosis. If the respiratory rate is greater than 30 breaths per minute, if the heart rate is exceeding 120 beats per minute, or if something called pulsus paradoxus is present. We will deal, I know you've dealt with pulsus paradoxus before when you did cardiovascular physical examination. We're going to review in detail on the Friday or the end of the week of the fifth hour of this presentation. Um, what pulsus paradoxus is, how do you measure this, and what is its significance. You will have to learn three possible causes, differential diagnoses for pulsus paradoxus. Number one would be asthma. If not, meaning this patient is not being sent to the hospital or 911 call, co-manage with a pulmonologist. There's been a couple of studies done in the past where chiropractic adjustment has been shown. Regular chiropractic adjustment in children that have asthma, uh, they don't get as frequent asthmatic attacks in the year during the study when the study was conducted. If they got asthma, they used less medication than is normal, and two, they were less likely to be hospitalized if they were under chiropractic care. In addition, not as opposed to chiropractic care versus no chiropractic care. It's chiropractic care plus their inhaler. Okay. So co-manage with a pulmonologist. The pulmonologist is going to confirm this is asthma by ordering a lung function test, and they're looking specifically for the forced expiratory volume expelled in 1 second after deep inspiration. They're looking for a value of less than 70%, which is diagnostic for asthma. Next, we're going to talk about emphysema, and then lastly, we're going to talk about chronic bronchitis. Emphysema and chronic bronchitis are the two examples of chronic obstructive airway disease. This is permanent, this is progressive, this is not episodic, this is irreversible airway damage. This variety of COPD, chronic obstructive pulmonary or airway disease, is also known as the pink puffer variety. The cause of emphysema is cigarette smoking, and if the patient has classic features of emphysema but never smoked cigarettes, then you have to consider the uncommon possibility that this patient with emphysema has a genetically inherited condition known as alpha 1 antitrypsin deficiency. Clinical picture of a patient with emphysema would be pursed lip breathing and barrel-shaped chest. They will have shortness of breath, and they would, because of the overinflation of the lungs due to the loss of elastic tissue caused by activated macrophages triggered by cigarette smoking and environmental pollution, the lungs expand but don't have the capacity to collapse on their own because of the loss of elasticity. The overinflated lung has to be encouraged to empty itself, and how the patient does this innately. Nobody has to teach the patient how to breathe if you develop emphysema secondary to cigarette smoking. What will happen is that they will instinctively cause contraction of the anterior abdominal wall, which will then increase the intra-abdominal pressure, which will then push the diaphragm up from below. And once the diaphragm is pushed up, it would then squeeze the lungs to force the air out of the lung. And in order to do this properly, they will purse their lips with expiration. And this is classic for emphysema. X-rays will confirm that the lungs are overinflated. You will see the diaphragm on both sides, the domes of the diaphragm flatten because of the hyperinflation of the lungs. The mediastinum would be squashed in the middle between the expanding lungs on both sides. And when you look at the lateral chest x-ray, you're going to see a large retrosternal window. And I'll show you these shortly. Management, you co-manage with a pulmonologist, and both of you will be tasked with the task of helping the patient to stop smoking, whether you encourage them to use a nicotine patch or nicotine chewing gum. It is imperative that they stop smoking. So here is what the lateral x-ray of a patient with classic emphysema looks like. The anterior posterior diameter is going to be markedly enlarged. This is your barrel-shaped chest. Here's the sternum. Here's the cardiac silhouette. And here is the large retrosternal behind the sternum area filled with air. And there's also a large area, another window that is behind the heart. So this is called the retrocardiac window. And the diaphragm, both of these diaphragmatic domes are going to be flattened. It is better seen on the PTA. This is a PTA film because the clavicles are almost horizontal as opposed to the medial parts of the clavicles going down in a V. This is a P to A as opposed to an A to P. Here's the overinflated lung fields. Here's the flattened domes of the diaphragm, and this is the squashed mediastinum. Remember, you should only be able to see 9 ribs posterior, and if you were to count the number of ribs here that you can see, you can go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and I can see the beginning of the 11th ribs, and you can do the same thing on the other side. Overinflated lung fields, flattened diaphragm, phragmatic domes, and squashed thin mediastinum. The other variety of COPD is chronic bronchitis. This variety is known as blue bloaters. The pink puffers, they puff away, pursely breathing, but nothing is wrong with the oxygenation of blood, and therefore their skin color is pink. In here, there is central cyanosis, so the skin tone color is blue, and then they're bloated because of right-sided heart failure. So chronic bronchitis is defined as part and parcel of the chronic obstructive airway disease, the same causes like emphysema, cigarette smoking, industrial pollution. The clinical picture. Now, for this to be called chronic bronchitis, there has to be the following 2 specific criteria. 1, chronic cough. For the diagnosis of chronic bronchitis, chronic cough is defined as having a cough that lasts more than 3 months. And in the context of chronic bronchitis, that chronic cough should be 2 years or more. So 2 things need to be in there before you can go, this is chronic bronchitis. If not, you go, this is bronchitis. It is a little longer than acute, but it's not yet 2 years. It might be going on to develop next year. So if we were to jump ahead of the game and say to the patients, you need to stop smoking cigarettes because you're damaging your lungs, this then doesn't develop into the full-blown 2 years or more, 2 consecutive years or more. In addition to the chronic cough lasting more than 3 months and 2 consecutive years or more, there will be central cyanosis. Note, this patient's lips are blue, this patient's fingertips are blue, and this patient's legs and feet are blue. Labs, the x-rays are going to show increased peribronchial markings. Management, you co-manage with a pulmonologist. You're going to try and get the patient to stop smoking cigarettes, and you're going to consider whether this patient with an acute exacerbation of his chronic bronchitis problem needs to be hospitalized. And the two criteria you're going to use is if this patient develops a fever. It might be due to the compromised lung is going to develop a pneumonia. This is best treated in hospital. Or the patient has once again pulsus paradoxus. Now, so there are two conditions you have to have in your differential diagnosis for pulsus paradoxus. I said to you a couple of minutes ago there were three. Now you know two. The first is asthma. The second is chronic bronchitis. Any questions? If there are no questions, we are going to move to the next diagnostic hub, which is shortness of breath or dyspnea associated with swollen ankles. By the use of the plural, I am implying this is bilateral ankle edema, not unilateral. In a couple of weeks from now, we're going to do unilateral versus bilateral edema. This is not unilateral, this is bilateral edema. So what are three common or important causes of shortness of breath and swollen ankles or bilateral edema? The first is congestive heart failure. Congestive heart failure is defined as failure of the heart to function as a mechanical pump. The causes, there are four causes you need to remember for boards. They are age related. So starting from the very old to the young, the commonest cause of heart failure in the elderly, which is defined as over the age of 65, is ischemic heart disease. And the most common cause of ischemic heart disease to result in heart failure is a myocardial infarction. If the patient is an older adult, but not the elderly, meaning between the ages of 40 and 65, the most common cause of congestive heart failure is hypertension. Hypertension causes cardiac hypertrophy, and then the hypertrophy could only grow so much before it starts to fail with the increasing pressure that it has to pump against, and the patient goes into starting with the left side, left ventricular heart failure, spreads to the lung, and then involves the right side of the heart. In the younger adult, meaning between 20s and 40s, the commonest cause of heart failure is valvular heart disease. And the commonest cause of valvular heart disease in America is problems with either the mitral valve becoming degenerative or calcified, or the aortic valve. Rarely is it a consequence of rheumatic fever as a child. In the rest of the world, the commonest cause of heart failure due to valvular heart defects in the young adult is a sequelae of rheumatic fever as a child. And if this was a child or a young teen with congestive heart failure, the commonest cause is congenital heart disease. The commonest congenital heart disease defect is VSD, ventricular septal defect, for the acyanotic variety. And if the patient is cyanosed, centrally cyanosed, again with the lips and the tongue and the fingers and the toes, the commonest cause of cyanotic congenital heart disease is Fallot's tetralogy. The clinical picture involves the presence of the following: dyspnea on exertion, DOE, that is what DOE stands for. PND, paroxysmal nocturnal dyspnea, and basal crackles. These three together says the left ventricle is failing. Now, when the fluid accumulates in the lungs and the pressure in the right, the pulmonary trunk increases, and then the pressure in the right ventricle and then right atria increases, you're going to get right ventricular failure. And the features of right ventricular failure are the other three, which would be raised jugular venous pressure. You'll see this in the neck in a patient sitting in the semi-fowler position or at 45-degree angle with head turned away so you can see the pulsations in the neck. A positive hepatojugular reflex. You press in the right upper quadrant slowly over the next 30 seconds and you will see increased venous pulsation in the neck. And then bilateral ankle edema. Those three, raised jugular venous pressure, positive hepatojugular reflex, bilateral pitting ankle edema, are expressions of right ventricular failure. Having separated out the two, most times when patients develop congestive heart failure, it's both ventricles that are failing, left followed by right. Rarely do you get right ventricular failure without left ventricular failure, and this would be due to problems that are related to the lung primarily. Chronic bronchitis, interstitial pulmonary fibrosis are likely to cause increased pulmonary pressure in the pulmonary arteries. Pulmonary hypertension will then cause right ventricular hypertrophy, which will then cause right ventricular failure. And when the right-sided heart failure is caused by pulmonary problems, remember there is a special name in pathology given to that combination, and that would be cor pulmonale. Cor for heart failure, pulmonale due to a lung problem. However, remember that you learned this for boards pathology. You're going to need to bring that back for boards part 2. The commonest cause of right ventricular failure is, finish the sentence, the commonest cause of right ventricular failure is, yes, left ventricular failure. And then second most common would be cor pulmonale. There would be Cheyne-Stokes breathing. Cheyne-Stokes breathing is defined as regularly irregular breathing, where the patient has bouts of rapid breathing, apnea, rapid breathing, apnea. This goes on in a regular pattern, and I'll explain the pathophysiology later on in this week when we do specific breathing patterns that are associated with specific conditions that are related to shortness of breath. So there's going to be Cheyne-Stokes breathing or respiration. And then there is a new feature. It has been around since 2014, and for some strange reason, despite the fact that people have accepted it as a good predictor of a bad or a poor prognosis with patients with congestive heart failure, it has not yet reached the standard textbooks. This is called bend-opnea. Pnea, P-N-E-A, has to do with breathing, so apnea, no breathing, tachypnea, rapid breathing, dyspnea, difficulty in breathing, bradypnea, slow breathing, bendopnea, increased breathing when you bend over as if to tie your shoelaces or put on your socks. And if a patient within 30 seconds of doing this activity has to straighten up themselves and take a couple of deep breaths to catch their breath again, That is not a good sign for the prognosis of their congestive heart failure. It means they should be hospitalized. They should be treated with not just diuretics, they should be treated with triple therapy involving beta blockers and angiotensin receptor blockers. Management of a patient with congestive heart failure: refer the patient to the hospital. Co-manage with them afterwards. And as I said, the presence, you are going to monitor them for bend apnea. So every time you would see them for whatever chiropractic issues you're dealing with, you're not going to go say, you have a cardiac problem, I'm not going to touch you. I'm treating the patient, not the subluxation. You're going to have them bend over for 30 seconds, pretend as if they're tying their shoelaces, and observe if there is an increase in the breathing, the respiratory rate. There are two labs that you need to know for boards. One is the best screening test, that is your BNP, B natriuretic peptide. It's a hormone that is produced by stressed ventricles. If the value is greater than 400 picograms per deciliter, you're more likely to be suffering from congestive heart failure. But the gold standard for the diagnosis of congestive heart failure is ordering echocardiogram, which would involve them being seen by a cardiologist. And if the ejection fraction is less than 40%, the normal is between 55% and 65% of the blood that is contained in each ventricle. There's approximately 110, 120 cc's of blood, and every time the heart contracts, it expels approximately 70 mils of that 110, which works out to be between 55 and 65% of the end diastolic volume. And if it is less than 40%, this is diagnostic of congestive heart failure. Here are the three features of congestive heart failure that you're going to need to learn for boards: radiology, parts 2 and 3, and for part 4. And therefore, I'm going to test you on this in your next examination, which is due in week 10. So the first of the three radiological features is cardiomegaly. You're going to measure the greatest diameter of the cardiac silhouette. You're going to compare that to the greatest diameter of the thoracic volume. And normally, the heart would be, and I'm going to outline where the heart should normally be. It should be around here. And if you were to measure that distance compared to that distance, the cardiac silhouette would be half of the thoracic diameter. If you were to measure this and compare this to half of the thoracic diameter, you would find that the cardiac diameter is greater than half of the thoracic diameter. So the first feature is cardiomegaly. The second feature you're going to look for is prominent pulmonary blood vessels. These are large, distended pulmonary veins and arteries that are chock full of blood because the blood is not flowing properly from the right ventricle through the lungs into the left ventricle, and the lung blood vessels are going to be dilated. So that prominent pulmonary vasculature is number 2. Some people, Dr. Che might call this a bat wing. Here's one part of the bat wing, here's the other part. Over here, bat wing appearance of bilateral prominent pulmonary blood vessels. And then the third would be out in the periphery. Near these recesses, this is the cardiophrenic or cardiodiaphragmatic recesses, you will see perpendicular lines to the periphery, and I'll show you in the next picture what these look like. What I'm asking you to see is these perpendicular lines in the region of the cardiophrenic angles. And these are curly B lines. They're actually three lines that were originally described by Dr. James Curley, radiologists in the last century, curly A, curly B, curly C. I am only interested in you learning the curly B lines, which is a feature which indicates that there is fluid in between the bronchopulmonary segments in the alveolar septa. So here is the prominent vasculature going all the way out to the periphery. That's your curly B lines, several of them in the region of the costodiaphragmatic or costophrenic angle. Another cause of shortness of breath with bilateral pitting ankle edema is nephrotic syndrome. Nephrotic syndrome is a chronic disease of basically the basement membrane, but sometimes it involves the glomerulus of the kidney. There are a number of causes. The important causes you need to remember is diabetes mellitus, so diabetic nephropathy, also known as Kimmel-Steele-Wilson disease or glomerulosclerosis, systemic lupus erythematosus causing lupus nephritis, and certain drugs, specifically penicillamine, that is used to treat some patients with rheumatoid arthritis, could induce damage to the kidney and producing nephrotic syndrome. The classic presentation of nephrotic syndrome is usually in young children, but can also be in young adults. They will present with puffiness of both eyelids, upper and lower eyelids, that is worse in the morning, and later in the evening there would be edema of the legs, and as this condition is progressive unless it's treated aggressively, the fluid will accumulate in the ankles, in the legs, in the thighs, and eventually in the abdomen, presenting with ascites. The diagnosis is confirmed that this is nephrotic syndrome, not the cause. Nephrotic syndrome is confirmed, so here's another value you're going to need to learn of having more than 3.5 grams of protein in a 24-hour urine sample. The other value that I said you needed to learn is diabetes mellitus. Diagnosis is clinched by having a fasting blood sugar of greater than 126 milligrams per deciliter. The third, which we just did a minute or two ago, which I did emphasize as one of the values you need to learn, a BNP greater than 400 picograms is diagnostic. The normal BNP is actually between 0 and 100. But only when it gets to above 400, then the specificity and the sensitivity is raised for you to go. This is a good screening test because it is 600 picograms per deciliter. Let's do the echocardiogram. So one of the labs, and this is the diagnostic lab, you need to remember greater than 3.5 grams of proteins in a 24-hour period. Now, if they're peeing out that amount of proteins in the urine, this obviously is going to cause a drop of the proteins in the blood. That decrease in the number of total proteins in the blood is called hypoproteinemia. Hypo, low protein, emia in the blood. One of the interesting findings in the lab, especially if you're going to order a lipid panel, is that you're going to see that the cholesterol in the blood is elevated. And the reason for this, the pathophysiology, is that the body sends a message to the liver to say, can you help out? The kidney is pissing out a lot of our protein on a daily basis. Could you make as much protein to compensate for the loss? And the liver says, sure. And one of the proteins that they produce in excess is lipoproteins, which is part of the cholesterol panel. There are two cholesterol values you're going to look for. You're going to look for the high density lipoproteins. You're going to look for the low density lipoproteins. The liver produces excess of these lipoproteins as a way of producing more proteins. And this hypercholesterolemia, high cholesterol in the blood, is going to spill out into the urine to form tiny little droplets of fat called oval fat bodies. And when hundreds of these oval fat bodies clump together, they're going to form the characteristic pathognomonic fatty casts that are diagnostic of nephrotic syndrome as far as you're concerned. If you suspect the patient having nephrotic syndrome from puffy eyelids early in the morning, bilateral pitting edema, some ascites, more than 3.5 grams of proteins in the urine in a 24-hour period, you're going to refer this patient to a nephrologist. A nephrologist is a medical doctor who's gone on to spend 4 years specializing in internal medicine, and then goes on to spend another 2 to 3 years specializing only in the kidney. Doesn't touch the ureter, doesn't touch the bladder, does not touch the urethra or any other part of the urinary system. His primary focus is on the kidney alone. So refer to the nephrologist. What the nephrologist is going to do is arrange, he will do this himself, for a renal biopsy. He's going to send that material off to the lab. The pathologist is going to look at this and he's going to say, oh yes, I see some glomeruli with round concentric fibrous deposits. This is classic for Kienle-Steele-Wilson disease. Or he sees with special staining, tram track or railroad or lumpy bumpy variety of the immunoglobulin deposition, or there is going to be very little changes seen on ultramicroscopy. This is called minimal change type of nephrotic syndrome. The most common type that is seen in children is the minimal change type, and this has a very good prognosis. And the nephrologist will then, having determined this is the cause, will then treat the cause, and hopefully the underlying changes that have occurred in the kidney will be removed and the kidney could recover given time. Because remember, the kidney is one of those organs that has cells that are halfway between labile cells that constantly regenerate and reproduce themselves and replace when they're damaged, to permanent cells like the brain, the cardiac muscle and skeletal muscle. The kidney is what is known as, and I'm having a brain fart right now. There's labile, there is permanent, and there is stable cells. It has stable cells which retain the ability to regenerate when pushed, constantly pushed to the wall to go, come on, you gotta do this. Then there's cirrhosis of the liver. Cirrhosis is defined as a chronic disease of the liver marked by degeneration of cells, inflammation of the hepatocytes, fibrous tissue thickening, replacing the damaged cells, and is typically as a result of alcoholism or hepatitis. The causes are alcohol abuse or chronic hepatitis B or C. Today, we need to add one more cause of cirrhosis, and this is non-alcoholic fatty liver disease, because of the epidemic in this nation that is now A little more than 40% of the adult population are overweight or obese. By using the BMI definition, greater than 30 is obese. Then more and more people are developing non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease is going to cause chronic inflammation on a long-term basis, which will eventually lead to cirrhosis. The clinical picture is protean, meaning there are more than 2 dozen possible manifestations of cirrhosis, and you can look over in the diagram on the right there and you can see these 2 dozen. I am not interested in you learning all the 2 dozen. Here's the ones I want you to remember. Swollen legs, because we're dealing with shortness of breath with swollen legs. Ascites, jaundice, yellow change in the sclera, fatigue, gynecomastia, and pleural effusion. We're going to come back later and talk about the ascites, how to detect the presence of ascites. We're going to come back and talk about if we find gynecomastia, what is the significance of the gynecomastia, what is its underlying pathophysiology. As I said, there are more than 2 dozen, and you can look at all of these. I'm going to come back and highlight a couple of these later. So as we're over here, I'm going to ask you put an asterisk next to palmar erythema, because that is one of the clinical features we're going to review in the very last lecture in this series. Labs. The labs you're going to order is your classic comprehensive metabolic panel. You're going to look specifically at the liver function part. So you're going to look at the total proteins. You're going to look at the breakdown of your total proteins into albumin and globulin. You're going to look at the albumin-globulin ratio. And then you're going to look at specific liver enzymes, AST, ALT, GGT. And you're going to look at the bilirubin, which will be raised. And it will tell you, is it primarily indirect bilirubin or direct bilirubin, otherwise known as unconjugated and conjugated bilirubin, or a combination of both unconjugated and conjugated bilirubin that is elevated. Management, you co-manage with a gastroenterologist. Your main function as a primary care physician is to encourage this patient to stop drinking alcohol. Any questions? If not, let's go to the next triad, which is shortness of breath associated with fatigue. I'm just dealing with 3 causes of fatigue right now that are associated with shortness of breath. When we do fatigue later on in the program, I think in week 9 or 10, we will cover 27 causes of fatigue. But right now, I just need you to focus on 3 of them. Fatigue associated with shortness of breath. The first is anemia. Anemia is defined pathologically, laboratory, as the presence of a low hemoglobin, low red blood count, and low hematocrit. The causes could be either deficiency in a number of important minerals or vitamins like iron, like folic acid, like vitamin B12, or it might be an excess of a toxic metal like lead, plumbism, which can cause an anemia. The clinical picture includes the following: shortness of breath, fatigue, pale mucous membranes, which would be the inside of the bottom eyelid, pale smooth tongue, stick your tongue out, pale fingernails, or the fingernails might be curved slightly up like spoons, koilonychia. If this is iron deficiency anemia, or It might be a beef red tongue, which is classic for folic acid and B12. Both of these causes of anemia and including iron deficiency anemia will be associated with tachycardia. And the patient obviously might present with palpitations as an expression of the increase in the heart rate that they perceive. Labs, you're going to order the complete blood count, and the complete blood count will show you low hemoglobin, low hematocrit, low red blood cell count, and depending whether this is a iron deficiency, folic acid deficiency, B12, or plumbism, aka lead poisoning, you would have either a microcytic hyperchromic anemia on one side, a macrocytic normochromic anemia on the other side, or a combination of a macrocytic hyperchromic or with chronic disease, a normochromic normocytic anemia. In addition to doing the CBC to one, confirm that there is anemia, two, determine which of the four morphological types of anemia, then you're going to do other tests that are going to be helpful in determining the etiology of the anemia, which we will cover shortly. You're going to order total iron binding capacity. You're going to order folic acid assay, B12 assay. You're going to order serum ferritin if you thought that this was an iron deficiency anemia. Management, refer to a hematologist. Let the hematologist determine if this is a iron deficiency anemia, which of the more than a dozen causes of iron deficiency anemia is. Because I would not be treating this patient with, oh, you have an iron deficiency. Let's load you up with 2 iron tablets 3 times a day. Come back and see me in a month's time, and you should be right as rain and not care about why are you actually iron deficient. So one of the causes of anemia would be folic acid or B12 deficiency. If you think this is a folic acid deficiency because it's a pregnant mother, or the patient is on anti-cancer therapy and the tongue is beefy red and smooth and painful, uh, folic acid deficiency will result in an elevation of your homocysteine level, but today we just do a blood assay. B12 deficiency, similar clinical picture: fatigue, tachycardia, tiredness, dyspnea on exertion, beefy red, smooth, painful tongue. Both homocysteine and methylmalonic acid are going to be elevated. Today we order just the blood assay. We ask the lab, please measure B12, and they will do that. Here is something that I said to you when we were doing a number of miscellaneous lab tests in week 3. Old-fashioned test for B12 is the Schilling test. It's a complicated 8-step process that is going to help to determine, is the problem in the intake, is the problem in the stomach with the secretion of intrinsic factor, is the problem with absorption in the terminal ileum, or is the problem with diphyllobotum latum competing with you for your B12 in the diet? You need to know the Schilling test is an old-fashioned test for B12, not folic acid deficiency, but this is only of historical significance. Diabetic ketoacidosis is another cause of shortness of breath and fatigue. Diabetic ketoacidosis is as a result of the excess production of ketones, which is seen primarily in type 1 diabetes mellitus. This is diabetes mellitus that is dependent on insulin for treatment. The other one that occurs not in children or teens, but in older adults and is associated with weight gain, is type 2 diabetes mellitus, and that is diabetes mellitus independent of insulin. What triggers the diabetic ketoacidosis in a patient with type 1 diabetes is an infection and stress, and that stress could be either physical stress or emotional stress. The clinical picture of this complication of type 1 diabetes mellitus is Kussmaul's breathing, um, rapid deep respiration or air hunger, and we'll talk about this later in the final lecture, and acetone on the breath when you ask the patient to say Happy Halloween or any sound. Um, Hanukkah would be fine. Um, you would smell this fruity acetone breath on their expelled air. The labs, you're going to order the urine analysis, and this is a routine urine analysis. The dipstick will tell you ketones are present, glucose is present in excess. Management, refer this patient urgently to the hospital. They need to bring that sugar down because the sugar in these patients is probably going to be in excess of 400 or 500 milligrams per deciliter. And that's diabetic ketoacidosis. The other cause of fatigue with shortness of breath is sarcoidosis. Sarcoidosis is a chronic systemic non-caseous. So underline the word non-caseous. This would then distinguish it from caseous necrosis, which is TB. So this is a chronic systemic non-caseous granulomatous disease that has a propensity of affecting the lungs primarily. 90% of all patients with sarcoidosis present with lung problems, and a smaller number will present with skin problems, eye problems, or problems with the spleen. The actual cause of sarcoidosis is still unknown. We know that this is more common in African American females, middle-aged African American females who would present with shortness of breath, SOB, dyspnea and exertion, DOE, fatigue, erythema nodosum. And here are the darkish red painful bumps that are found on the anterior aspect of the legs, not the posterior. This is called erythema nodosum. This is one of 5 red skin lesions you need to be familiar with and be able to distinguish this between or this from erythema infectiosum, erythema multiforme, erythema migrans, and one other erythema. So erythema nodosum, erythema migrans, erythema multiforme, erythema infectiosum, and the erythema that is seen classically in rheumatic fever, erythema marginatum. And we will cover all of those, and you will get probably a question on all of them sometime in this second exam or in your final examination. The labs for the third time, very peculiar findings, leukopenia. So we know this is not an infective process, because if this were an infective process, there would be leukocytosis. The white blood cell count is going in the opposite direction, low white blood cell count. And when you order the CMP, the serum calcium would be elevated. We do know that in sarcoidosis, the activated macrophages will then trigger the conversion of inactive vitamin D into active vitamin D3, which will then cause increased absorption of calcium from the gut into the blood. So the combination for the 5th time of leukopenia plus hypercalcemia is seen only in, as far as you're concerned, in sarcoidosis. Co-manage with a pulmonologist. The pulmonologist will then know how to deal with this. In addition to the red bumps on the legs, an uncommon presentation of sarcoidosis is iritis. Iritis will present with painful red eye. It's usually bilateral rather than unilateral, so it's in part and parcel of your differential diagnosis with acute glaucoma and conjunctivitis that we did a couple of weeks ago. So iritis could be a manifestation of sarcoidosis. And splenomegaly. For some strange reason, the spleen is enlarged 3 to 5 times. You can feel the enlarged spleen, and this would be indicative of sarcoidosis. An old test called the VIME test. I don't know if you did this in microbiology. VIME is spelled Kviem. In the past, 100 years ago, they would take uh, the spleen from a patient with confirmed sarcoidosis, desiccate the spleen, dry it out, pulverize it, pour some of the powder inside alcohol, extract from the powder a purified derivative like your Mantoux test, where you use PPD. You're going to take some of this purified material from a patient with sarcoidosis, inject it into the skin, and you are going to read this 48 to 72 hours later. I'm sure you would remember that when you did hypersensitivity reactions in either pathology, general pathology, or in immunology, you would have remembered that the Mantoux test was an example of a type 4 or delayed hypersensitivity reaction because the reaction is not immediate. It takes 2 to 3 days before the reaction is visible. The VIME test, spelled with a K, which is indicative of sarcoidosis, is also an example of a type 4 hypersensitivity reaction. And you would have learned then that both TB, tuberculosis, and sarcoidosis are examples of a delayed hypersensitivity type of reaction disease. So that would be the link between knowing that there is splenomegaly associated with sarcoidosis. Any questions? Let's look at another 3 diseases where the history does not give us the diagnosis. Adding the physical examination does not give us the diagnosis because maybe the underlying physical signs were not big enough to be noticed either with inspection or palpation or percussion or auscultation, and you needed to take a chest x-ray or some radiological examination to find what's wrong with the patient presenting with shortness of breath. So here is an x-ray that is typical of this particular disease. This is a P to A film because the medial edges of the clavicle are lower than the lateral edges, forming a V. We look at the trachea. It is central. We find that the aortic knuckle is slightly prominent, but the cardiac diameter compared to the thoracic is within the normal range, which is cardiac diameter is less than half of the thoracic diameter. We look in the apices and we see, so we're going to divide up the lung fields into the upper zone, the middle zone, the lower zone. We compare both sides. We see no unilateral mass that would make me think this is a Pancoats tumor. There's no apical consolidation or cavitation, so this is not TB. We come down here. We don't see any prominent pulmonary vessels. We don't see any prominent lymph nodes. But when we come down primarily in the lower zone. We're starting to see these circular lesions. We start a number of them, these circular lesions, and then we're seeing what are called railroad tracks to outlines of bronchi. This is classic for a condition known as bronchiectasis. This is classic for bronchiectasis. Here are these ring-like shadows. Over here are your tram track lines, peribronchial thickening, more ring-like structures. So this is bronchiectasis, a chronic inflammatory lung disease. It is defined as a condition that is characterized by chronic dilatation of the bronchi. It could be congenital. The infant is born with this for some strange reason, or it could be acquired. If it is acquired, it may follow whooping cough, cystic fibrosis, or chronic bronchitis. The clinical picture of bronchiectasis is shortness of breath with chronic cough and copious mucopurulent sputum. They actually are known to get up in the morning and start to cough, and they have by their bedside a cup. And they can fill that cup half full, coughing and coughing and coughing until they clear all of the secretions out in the morning, and then they're fine for the rest of the day. They may cough occasionally, and they repeat this process again the next day. Shortness of breath, chronic cough, and copious mucopurulent sputum. Some people have described the sputum as nummular, round like a coin, a quarter-sized coin, and this is how thick and copious the nummular sputum is. Lab, the pulmonologist to whom you are going to refer this patient for the special examination is going to order something called a bronchogram. The patient is going to be given a particular compound that is aerosolized to inhale, and the inhaled particles will stick to the bronchial wall. And when you take an x-ray afterwards, you will see the outline of the trachea. You can see the right main stem bronchus, the left main stem bronchus, and then you have the upper lobe, the middle lobe, and the problem is primarily in the lower lobe in both of these lungs, where you can see saccular dilatation of the bronchi in this special x-ray known as a bronchogram. So this is the discussion on pleural effusion. Pleural effusion is defined as the presence of excess fluid in one pleural cavity. It could be bilateral. This one is one-sided. Here are some causes: pneumonia and TB, nephrotic syndrome and congestive heart failure, pleural metastases. And I've grouped these 5 deliberately into these 3 categories: TB and pneumonia because these are infections, nephrotic syndrome and congestive heart failure. These are problems that would affect the pressure, either the oncotic pressure or the hydrostatic pressure. And pleural metastases because the cause of the effusion is due to cancer spreading from inside the lung to outside the lung, affecting the pleural space. When this patient goes to the hospital, what they're going to do, the doctor is going to aspirate out as much fluid as they can. They're going to look at this fluid visually to see if it is clear, if it is cloudy, or if it is blood tinged. And then they're going to send it off to the lab to confirm that the cloudiness is actually due to the presence of tons of white blood cells The clearness is due to the presence of increased proteins, and the blood tinge is due to not only the presence of blood, but they will spin this fluid down and they will see cancer cells in the centrifuge sediment down at the bottom as indicative that the cancer has spread to involve the outside covering of the lungs. So pneumonia and TB is likely to give you cloudy fluid, otherwise known as an exudate. Nephrotic syndrome and congestive heart failure is going to give you a clear effusion, otherwise known as a transudate, and your pleural metastases coming from nearby cancer is going to give you a hemorrhagic effusion. Clinical picture: shortness of breath, localized stony dull percussion note, absent breath sounds over the area that is replaced by fluid. In a large pleural effusion, the trachea will be pushed over away from the side of the effusion. So this is a large effusion on the left and the trachea is pushed over to the right. As I said, the radiological features were: 1, obliteration of the costophrenic angle; 2, sign of the meniscus, and depending on the size, you may or may not get a displaced trachea. Treatment of a patient with a suspected pleural effusion: refer to the hospital. They're going to hospitalize the patient, aspirate, look at it visually, send it to the lab, and treat the cause of the effusion rather than just take the effusion out. So pleural effusion is not the final diagnosis. It would be pleural effusion secondary to congestive heart failure, pneumonia, nephrotic syndrome, CHF, or lung cancer that is spread to involve the pleura. Here's another disease which presents with shortness of breath, and not too sure why we would have missed this on our physical examination. Maybe because the patient was in the hospital and we weren't too sure what was wrong, because he was lying in the hospital and there are tubes all around and inside this patient. And I'll tell you why I say this shortly. So here is the x-ray. Again, this is a P to A. Here's the trachea slightly pushed over to the right side because of a problem on the left. The upper zones are okay. The middle zone here is fine. The lower zone on the right side is fine. I can see clearly the right costodiaphragmatic angle. I can see clearly the right cardiodiaphragmatic or cardiophrenic angle. But when I go over here, I can't see the left costophrenic angle because it is obliterated. It is obliterated by fluid. And I know it's fluid because up the top of the fluid, there is this curve. This is called a curvilinear line, otherwise known as the sign of the meniscus. So the combination of obliteration of one costophrenic angle, curvilinear line up at the top, or the sign of the meniscus, and a displaced trachea away from the side of the pathology are the 3 radiological findings of a pleural effusion. This is a pleural effusion. Do you notice anything else wrong with this x-ray? I want you to look at these here. You see that there? See that there? See that there? There are a whole number of them. These are wires that are around the sternum, and this patient recently underwent a triple bypass for a heart attack, and they got him in time, and to get to the heart, to do this as an emergency, they had to split the sternum in 2. They split the sternum in two. They pushed aside the left lung because they needed to push the left lung away to get at the left anterior descending artery and the circumflex artery to do the bypass, either using a piece of vein taken from the leg, or they're taking part of the terminal portion of the internal thoracic artery and anastomosing it with the left coronary artery after the obstruction. Because you have traumatized the left pleural cavity and the lung, postoperatively this patient presented with this particular picture. The fluid would have accumulated on the posterior aspect of the chest. So while they might have been able to auscultate the anterior chest, they were not able, because the patient was in the supine position. They couldn't get around comfortably to the back to then determine their absent breath sounds in the left bass. The percussion note is stony dull, and the vocal fremitus and vocal resonance has changed to indicate the presence of pleural effusion. So this is a small pneumothorax. It has an asterisk which tells you what. We've done this already, and therefore we're not going to, for the sake of time, go over this. Okay. All right. So we have this X-ray that we're looking at in a patient with shortness of breath. And if we don't see the obvious cause of the shortness of breath, this would be a good time to use the ABCDE approach to see if that can't really help us. So remember the ABCD approach that you were taught by Dr. Che. A is for airway. So we're going to look at the trachea. The trachea is okay up here, but starting to come down here, there's a slight deviation to one side. It's deviated slightly to the right. We're going to do the air fields. We're going to compare the upper zone with the middle zone with the lower zone, and this looks okay. We can see the cardiophrenic angle. We can see, the costophrenic angle. We can see the cardiophrenic angle here. We come over here, and this is looking a little darker. Then over here you can see the bronchopulmonary markings going all the way out to the periphery, and you see bronchopulmonary markings here and nothing there. You can see bronchopulmonary markings going out there, and then yes, here is the faint outline of the partially deflated left lung. This could be subtle. And the reason this was not picked up on the X-ray, on the physical examination, was that it wasn't large enough to give you the hyperresonant lung fields on percussion and the absent breath sounds that are typical of a full-blown pneumothorax. So this is a partial pneumothorax involving the left lung. Once again, here is the outline of the partially deflated left lung. Any questions? If there are no questions, we'll then go to the second part of this presentation. We're going to review the laboratory tests from a summary perspective, and then we're going to cover some of the more important physical science that we kind of tangentially mentioned. The first lab test we talked about is your B-type natriuretic peptide. Remember I said to you, this is a hormone that is secreted only when the ventricles are stressed. It's a peptide hormone that is going to be a diuretic. The uretic part of this word comes from diuretic. The natria comes from natrium, which is the chemical word for sodium. So this is a naturally occurring diuretic hormone that is of a peptide origin. So proteins were made, uh, were used to make this, and it was a diuretic aimed at causing sodium to be excreted into the urine. This works primarily at the proximal convoluted tubule level. Acts on the kidney, elevated primarily in congestive heart failure. We're looking for a value greater than 400 picograms per deciliter. Next, we talked about ordering a complete blood count if we had a patient with shortness of breath, presenting with fatigue, looking for evidence that an anemia is the cause of the problem. Or we're going to look at the white blood cell count if we thought this was an inflammatory infective process. So complete blood count, if anemia was suspected, we're looking to confirm that the anemia is present by finding in the lab report low red blood cell count, low hemoglobin, low hematocrit. And if this were an iron deficiency anemia, then the mean corpuscular volume would be down. This would be a microcytic kind of anemia. And the mean corpuscular hemoglobin concentration would also be down. This would be a hypochromic anemia. If this were a bacterial infection, we're looking for leukocytosis and we're looking for neutrophilia. And remember, if this were sarcoidosis, because we saw shortness of breath associated with fatigue, and we saw these strange dark red bumps on the anterior aspects of the legs of a middle-aged African American female, then leukopenia would be indicative that we're dealing with sarcoidosis. The comprehensive metabolic panel, if we looked and found that there was hypercalcemia in the UNE portion, and this is the UNE portion, the bottom portion here would be the liver function test. So hypercalcemia is going to be seen in sarcoidosis, and the combination with hypercalcemia and leukopenia tells you definitively this is sarcoidosis. If this patient had nephrotic syndrome and was losing more than 3.5 grams of proteins in a 24-hour urine collection, then that would result in a drop in the total proteins. This is known as hypoproteinemia. The lab might at this stage give you the albumin globulin ratio, and the albumin globulin ratio will be reversed not only in multiple myeloma but also in severe nephrotic syndrome. A special test needs to be ordered if you had a patient with shortness of breath and sticking chest pain. You're suspecting this patient might be having a pulmonary embolism. Ordering the D-dimer is going to help you to rule out the possibility of a DVT PE if the test is negative. It will be elevated if the PE is caused by a DVT, which is 98% of all pulmonary emboli. This has a very high sensitivity, but a very low specificity. So having a positive DVT does not mean that this patient has a pulmonary embolism to account for their sudden onset of shortness of breath, sticky chest pain, and hemoptysis. However, if you thought this was PE and your DVT was negative, you can comfortably go, nope, If this is PE, it is not due to DVT. It might be due to fat embolism, amniotic fluid embolism, or air embolism because of the very high sensitivity of this particular test, 95% sensitive. Echocardiogram was used or will be used or should be used if you suspect a congestive heart failure and your B-type natriuretic peptide value was greater than 400 grams per deciliter. This is the confirmatory test for heart failure. It's a specialized heart test. They use ultrasonic waves. They use the same ultrasound probe with a slight modification because they have to go through the chest wall. Here's the echo. It will show you in this still picture. Here is the left ventricle, and the left ventricle is much larger than the right ventricle, so this will fit very well with left ventricular failure. Here's the left atrium, and they actually measure how much of this volume is ejected during systole. The normal ejection fraction is between 55% and 65%. If this were less than 40%, then that's the gold standard for diagnosing the presence of ventricular failure, heart failure. Then we mentioned the FEV1. FEV1 stood for force expiratory volume in 1 second. This is a spirometry picture where we ask the patient to breathe in normally. This is the tidal volume, in, out, and then we ask the patient to take as deep a breath as possible and force it all the way out. And then they measure the amount that comes out in 1 second. Normally it is 80% and above. If it is less than 70%, this is diagnostic of asthma. If you had a patient with anemia and the lab said there was low hemoglobin, low hematocrit, low red blood cell count, and the MCV was low and the MCHC were low, so you have a microcytic hyperchromic anemia, and the common cause would be iron deficiency. It could be lead poisoning, or it could be thalassemia. But we're just going to look just between lead poisoning and iron deficiency. You order the total iron binding capacity. The total iron binding capacity is a measure of the blood's ability to carry more iron. If you have less iron in the blood, then the capacity is elevated. Therefore, your TIBC is raised in iron deficiency. If you have hemochromatosis, which is iron overload, often a hereditary problem, the body uncontrollably absorbs every bit of iron from the duodenum and the small bowel into the blood stored in the liver, because the body doesn't have the wherewithal to excrete excess iron, and there's loss of a control mechanism inside the enterocyte. Then iron just accumulates over and over again, and therefore the total iron binding capacity is going to be markedly decreased. In lead poisoning, this heavy metal displaces the iron that is used in the production of hemoglobin. Even though the iron is not deficient in the blood, the iron is not allowed to make red blood cells properly, and the red blood cells behave as if they were iron deficient, but your total iron binding capacity will be normal in lead poisoning. So you need to remember that. Any questions? Let's finish this up by looking at some physical signs or tests. So first, remember this is arranged in an alphabetical order. We're going to look at abnormal breathing patterns. There are four of them. The first is the breathing pattern that is characteristic of congestive heart failure. It is Cheyne-Stokes breathing. Cheyne-Stokes breathing is defined as having an alternating pattern of apnea, no breathing with rapid breathing. It is also could be described as regularly irregular because it's regularly there's going to be no breathing. Then there's going to be rapid breathing, and then it's going to be no breathing. And then it's going to be rapid breathing, and then it's going to be no breathing. And this is classic. This pattern is classic for congestive heart failure. The next, which is described as irregularly irregular respiratory pattern, is called Bio's respiration. And Bio's respiration is due to compression of the brainstem, where for whatever reason, whether you have a space-occupying mass, increased intracranial pressure, the pressure forces the brainstem through into the narrowed foramen magnum and then compresses the vital centers, including the centers that control both inspiration and expiration that are located in the medulla oblongata. There's going to be bouts of rapid breathing, bouts of slow breathing, bouts of no breathing, but there's no rhyme or reason or rhythm to the pattern. So it's irregularly irregular. The third, which we've talked about before, is the rapid, deep respiration, otherwise known as air hunger. This is seen in diabetic ketoacidosis. You may want to underline the K in ketoacidosis and then underline the K in Kussmaul's respiration. The pathophysiology for this is straightforward. In diabetic ketoacidosis, the ketone bodies are acidic in nature. It changes the pH of the blood from the normal, which is 7.35 to 7.45. It makes it acidic, 7.1 or 7.2. The change in the pH stimulates the inspiratory nuclei that are found in the dorsum of the medulla, and the patient takes a deep breath. He doesn't continue to take a deep breath because there's a reflex that kicks in at this point called the Herring-Burr reflex that prevents the lungs from over expanding and exploding like a balloon inside you, and then it then stops the stimulation of the dorsal inspiratory respiratory nucleus in the medulla, and then you let that breathing out, but the pH hasn't changed, and you take another deep breath. And the body is attempting to blow off carbon dioxide through the lungs because it wants to create a respiratory alkalosis to then compensate or combat the metabolic acidosis that is seen in diabetic ketoacidosis. And the fourth of the abnormal breathing patterns is in hyperventilation syndrome, where you have rapid shallow breathing. Like if you're going to go into a panic attack, but remember we talked about ways of distinguishing between a panic attack and hyperventilation. One is associated with an intense trigger of fear that is going to come on suddenly, and the other one comes on gradually. And there are three other ways to distinguish between hyperventilation and panic attack. We mentioned the phenomenon known as bronchophony. Broncho to do with bronchus, phony to do with sound. So this is a sound that is made when the bronchial sounds are exaggerated. You're going to ask the patient to say 99 every time you touch them with a stethoscope. So you may want, what I do is touch them on the shoulder with a stethoscope to see if they have understood my instructions. They listened and they understood. So I touch them in the shoulder and they take a deep breath. I go, that's good. And I start off up at the top here. And you're going to go in this pattern. There are 10 particular spots that you have to cover. This could very well be a part 4 station in which the patient presents with symptoms of an underlying lung problem. It could be a pneumonia, which is often common. Patient presents with shortness of breath, chest pain, and a fever. You go, tick, tick, tick. Yep, that's a pneumonia. They say to you, would you like to demonstrate auscultation of the posterior aspect of the chest? Sure. And you are going to then start your examination process by, first of all, exposing the patient. But before you do that, you say to the patient, this is what I want to do. I want to listen with a stethoscope to the back of your chest to see what's going on in your lungs. Could you please take your shirt off for me? Good. Could you please fold your arms across your chest, because you want them to pull the shoulder blades out of the way, and then you say to them, every time I touch you, I want you to take a deep breath in and out, or in this particular situation, every time I touch you, I want you to say 99. And you go 1, 99, 2, 99, 3, 99, 4, 99, 5, 99, 6, 99, 7, 99, 8, 99, 9, 99, 10, 99. And those are the 10 places you will get marks given that you've covered the 10 places. So every time you say 99, every time you touch them with a stethoscope, they should say 99. And then you would say to the examiner, would you like me to tell you what I was listening for? Sure. If the sounds appeared louder in one particular portion, and they will tell the patient, when you're asked where do you have the pain, they will point to the right side of the chest. So you would be saying, if the sound appears louder than normal, when I place the stethoscope and ask the patient to say 99, then bronchophony would be present. And the examiner would say, okay, you heard the word 99 loudest over the lower portion of the chest posteriorly on the right side. What does this mean? It means consolidation is present. Usually this is a pneumonia, or sometimes it could be localized atelectasis seen in TB. However, remember where I said TB had a predilection for? Not the basis of the lungs, but in the apices of the lungs. So if this patient had in the history chronic cough, night sweats, small amount of blood in the sputum, and maybe a little weight loss, you should be suspecting that this is tuberculosis, and therefore would be expecting to find your findings on auscultation and palpation and percussion in the apices of the lungs, not the bases. Okay, so please remember that. Bronchophony primarily seen in consolidation, seen in pneumonia, but if this was seen anywhere else but the bases, up in the apices, this is a possibility that the consolidation in the apex could be associated with tuberculosis. Crackles. Crackles are defined as adventitious sounds on auscultation of the chest. Again, the examiner may say to you, I want you to auscultate the posterior chest wall. And even though the patient might have been complaining of pain on the right side, in the lower portion of the right, you are going to examine both lungs. You're going to start off in the apices on one side, going over the 10 spots. Again, your instruction will be tell them what you want to do, have them strip down, pull their arms across the anterior chest, and you say to them, every time I touch you with the stethoscope, I need you to take a deep breath in and out. So you don't have to go in, out, in, out, in, out, in, out. You just put the stethoscope there, and if the patient understood you, they're going to go, and then you move to the other side. Crackles are described as short, discontinuous, non-musical sounds. And you should have learned in the trimester that you did examination of the chest how crackles sound like. If you didn't, then do this for me. For those of you who have enough long hair in front of your ear, pull down a couple strands of the long hair and place them between your index finger and your thumb and roll them in between there in front of your ear, and this is what you will hear. And that is what the short, discontinuous, non-musical sounds known as crackles. They're usually heard on inspiration. So you would hear as they're taking a deep breath in inspiration. When crackles are present, basically in the basal parts of the lung, this could be pulmonary edema, pneumonia, or chronic bronchitis. They say that pneumonia and edema are going to cause fine crackles, and chronic bronchitis is going to cause coarse crackles. The next finding we will discuss is cyanosis. Osis condition, cyano, is the Greek word for blue. So cyanosis describes the bluish discoloration of the skin. It could be either peripheral or it could be central. In peripheral cyanosis, only the fingers and toes are blue, not the lips or the tongue. Could be due to exposure to cold, peripheral arterial disease, which limits the amount of blood going through the narrowed arterial blood vessels, Raynaud's phenomenon, which is associated with vasospasm, and then you get the classic white, blue, red discoloration when triggered by cold or emotions, or it could be evidence of arterial embolism in which a piece of clot is broken off from an atherosclerotic plaque in the abdominal aorta, gets stuck out in the periphery of one limb, and then that one limb is going to be blue. The other limb, the hand, would be pink and normal. Then there is central cyanosis. Central cyanosis occurs when there's a problem with the chambers of the heart. Blood on the right side mixes with blood on the left side, or you have a problem with oxygenation of the blood in the lungs. In that scenario, not only is the blood going to the tongue and the lips coming out from the left ventricle going up into the common carotid arteries, is going to be carrying a mixture of deoxygenated blood with oxygenated blood, but the same admixture of oxygenated and deoxygenated blood is going to go into the upper limbs and the lower limbs. So please remember this. In central cyanosis, the lips, the tongue, the fingers, and the toes are all blue. If this were seen in a infant or a child, you have to think of Fallot's tetralogy. Fallot's tetralogy is the most common. Cyanotic congenital heart disease, ventricular septal defect, which is the most common. Congenital heart disease does not cause mixture of blood from the right side of the heart to the left side of the heart, and therefore does not result in cyanosis. Chronic bronchitis, which affects the ability of the lungs to oxygenate the blood coming from the right ventricle to get into the left ventricle, is markedly affected, and therefore the lips, the tongue, the fingers, and the toes are going to be blue. Severe asthma, which affects the ability of the lungs to oxygenate the blood. Acute respiratory distress syndrome, in which the diffusion of oxygen from the alveoli into the pulmonary blood vessels is markedly decreased by the presence of proteinaceous fluid filling the alveoli. And pulmonary embolism, if it affects one lung entirely, and therefore the body is only working off of the oxygenation of one lung rather than two, you're going to have a marked decrease in the oxygenation, a marked increase in the deoxygenation of blood, and therefore central cyanosis. Agophony, and I say that deliberately, agophony is the air sound that is heard, phony, when you ask the patient to say the letter E every time they feel the stethoscope touch them. And remember, we're using a patient with pneumonia, and the pneumonia is located primarily in the right base of the lung. So you're touching the patient with the stethoscope and you're saying to him, every time I touch you with this and you feel me touch you, say E, E. So they go E, 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 E. So when the letter E sounds like the letter A, agophony is present. Agophony is the Greek word for sounding like the bleating of sheep or goats. This again is associated with pneumonia, which tends to affect the basal aspects of the lung, and TB, which tends to affect the apical aspects of the lung. So agophony present in one of the apices or both is indicative of possibility of tuberculosis. Erythema nodosum, as I said, one of 5 erythemas you have to remember, is described as red, tender bumps on the anterior aspect of the legs or the shins, not the posterior. And this is due to chronic inflammation of the underlying fatty tissue. The underlying fatty tissue, if you were to biopsy this inflamed tissue, you will see evidence of chronic granulomatous non-caseous necrosis. And that is classic for sarcoidosis. If you saw caseous necrosis, it would be TB. Non-caseous necrosis could also occur in Crohn's disease and ulcerative colitis. So erythema nodosum, sarcoidosis. Anytime you mention sarcoidosis as a diagnosis, you have to have TB as your differential. Crohn's disease, and anytime you mention Crohn's as a differential for abdominal pain with diarrhea, you have to mention ulcerative colitis. They tend to go together. Sarcoidosis and TB, Crohn's disease and ulcerative colitis, these are all known causes of erythema nodosum. We talked about jugular venous distension as a manifestation of congestive heart failure. Distended jugular vein, and here is the sternocleidomastoid. That's the mastoid end. This is the sternal end and this is the clavicular end. There's a small triangular space. This dilated vein that runs superficial to the SCM is not the internal jugular vein. That's the external jugular vein. And distension of the external jugular vein is unreliable to be used as a feature of either congestive heart failure, cardiac tamponade, or superior vena cava syndrome. What you're looking for is in front of the SCM. You split the SCM into half, and you're looking for this pulsatile swelling that is going to be in front, the upper part of the anterior portion of the SCM. And you will notice that there are going to be three instead of one pulsation. One pulsation would be a pulsation reflecting the underlying carotid artery in the carotid sheath. This is the internal jugular vein with its three pulsations A, C, and V. Raised jugular venous pressure is indicative of raised pressure in the right ventricle, being pushed up into the right atrium, being pushed up into the inferior vena cava, being pushed up into the internal jugular vein, which joins on with the subclavian vein to then form the superior vena cava. It could be indicative of congestive heart failure, cardiac tamponade, or superior vena cava obstruction. PND, otherwise explained or extrapolated as paroxysmal nocturnal dyspnea, paroxysmal once again for the fourth time, sudden onset, nocturnal night dyspnea, shortness of breath, is described as sudden onset of shortness of breath at night. In this situation, the pathophysiology is that extracellular fluid absorption results in edema in the lungs. And when the edema forms in the lungs, it is worse when you're lying down as opposed to when you're standing up. And when the patient stands up or sits up out of bed, the extracellular edema disappears. It goes back inside the lungs. It gets settled out in the lumbosacral region. And if you were to have this patient sit out of bed for the rest of the night and you come and examine his back early in the morning before you get out of bed, you would then press over the SI joints and then you will see indentation. So there would be pitting sacral edema. You may not see ankle edema in this position if they've been lying in bed. If they get up and walk and throughout the day, towards the end of the day, that extra fluid that caused edema in the lungs to then go to edema in the sacral region will present as edema in the legs. So PND is mainly caused by congestive heart failure. As far as you're concerned, for your boards, PND is pathognomonic for congestive heart failure. It has a 52% sensitivity and 83% specificity. Orthopnea, ortho to do with change of position, pnea to do with breathing, is also known as positional dyspnea. Shortness of breath that is precipitated by lying flat on the back and is relieved by sitting up. So the first symptom of congestive heart failure is in this order: paroxysmal nocturnal dyspnea. It only bothers them sometimes at night when it wakes them up suddenly. If they ignore this next couple of days, they will find that it's uncomfortable to lie and fall asleep flat on my back. I need to use a pillow or two. I use two pillows instead of one, and I feel comfortable. A couple nights later, I'm sleeping on three pillows. In fact, I can't sleep in my bed. I come out in my lazy boy and I sit in my lazy boy and I go to sleep in the seated position. If that doesn't worry the patient, the patient's wife should go, I don't like this rattling in your chest that I'm hearing, and that you're having to sleep upright in the lazy boy. I'm going to take you off to see your doctor. This is orthopnea. And the pathophysiology, again, is the extracellular fluid that absorption that leads to the fluid coming out into your alveoli and giving you pulmonary edema. So this is again seen in congestive heart failure, and this is following the paroxysmal nocturnal dyspnea that you have ignored. Now you have orthopnea. Sensitivity close to 90, specificity 60%, because it is not that a specific sign for congestive heart failure. It's more a sensitive sign for congestive heart failure. There are other things that could cause pulmonary edema besides congestive heart failure. We talk about bendopnea, another term for bendopnea, because apparently when this was first written up in an article in a journal in 2014, somebody says, excuse me, you're talking about paroxysmal nocturnal dyspnea, you're talking about orthopnea, platopnea, bradypnea, tachypnea. Why are you using bend for bendopnea? Isn't there an equivalent Greek or Latin word? And somebody says, yes, it's called campto. So camptopnea is the proper term for bendopnea. This is because the pathophysiology, when you bend over, you increase the pressure inside your abdominal cavity, which then forces blood to go from your abdominal cavity through the inferior vena cava, filling up the right atrium and the right ventricle. So you put more pressure on a failing right ventricle, and this is going to trigger the shortness of breath. Again, congestive heart failure is the indication, and it has a relatively high specificity. So when it's present, 85 to 91%, you think, no, this is congestive heart failure. And remember, I said it has a poor poor prognostic indication. Percussion note, you again going to ask to do this in the patient in which it is suspected of having pneumonia. You're going to tell the patient what you want to do. You're going to have the patient take the shirt off, expose the chest adequately, and then you're going to percuss in the same 10 areas: left, right, right, left, left, right, and you're going from top to bottom. You ask the patient again to fold their arms, to pull the scapula away so you can percuss directly over the rib cage. And with the tip of your middle fingers, sharply, this is of your right hand, sharply strike the distal interphalangeal joint of your middle finger in of the other hand. So right hand tapping, left hand is the pleximeter. There's a big fancy word for the tapping finger that's called a plexor. If you're right-handed, switch hands if you're left-handed. Note the quality of the percussion note. This is what it normally should sound like. I'm percussing over the chest. I'm now going to percuss for argument's sake over the heart where there should be no lungs. Hear the difference? So there's a change in the percussion note from hollow to dull. If the percussion note is increased, then you're dealing with emphysema or a pneumothorax. If the percussion note is decreased, you're dealing with a pneumonia. And if it is decreased to the point where it's described as stony dull, then you're dealing with pleural effusion. So let's show you what increased percussion note sounds like. This is what decreased sounds like. This is what stony dull sounds like. You hear the difference? Increased, decreased, dull. Next is pulsus paradoxus. It's pulsus tells you it's a test you're going to do while palpating the pulse. Paradoxus is kind of a misnomer. A paradox is where you're expecting A to be followed by B. You're not expecting A to be followed by L, and that's paradoxical. This is actually an exaggeration of a normal phenomenon, and I'll show you. I'll ask you to do it to demonstrate that normal people this happens, but then this is going to be an amplified response. Pulsus paradoxus is defined as a drop in the blood pressure that is greater than 10 millimeters on inspiration. So you look at the figure on the side, you have take a deep breath, inspire, and then blow it out. And look what happens on the top of inspiration. Your pulse pressure drops, and this is the normal pattern. So if you were to take a deep breath, so what I'm going to ask you to do is quiet yourself. You're going to feel your right radial pulse with your left hand if you are, whichever one you want to do. You're going to feel one pulse with the other hand. Get comfortable. You feel your pulse. What you're going to do is, I'm not going to ask you to do it until I tell you to do it. I'm going to ask you to take a deep breath in and hold it. And note what has happened to your pulse volume. Your pulse rate may change, but I'm not interested in the pulse rate. I'm interested in the force of the pulse you're feeling underneath your three fingers of your other hand. So let's do that. Feel your pulse. Take a deep breath slowly. And hold your breath and let it out. And what you should be able to feel if you are normal is, and I'll sound the volume, and if the volume drops, I will drop my voice. So take a deep breath in, bup, 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 hold it, bup, 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 let it out, bup, 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 and you do that again, and that is the normal variation. Now, when you do that with a patient, and if you were to concomitantly measure the blood pressure on the same side that you are palpating, what you will see is that the blood pressure may drop a little bit, but if the drop is greater than 10 millimeters of mercury, then this is pulsus paradoxus. The pathophysiology is interesting. When you take a deep breath, there is more blood that is going to fill your right ventricle. This is going to cause your right ventricle is going to expand. It's going to cause your left ventricle to slightly contract because the right ventricle is filling. And if you cause your left ventricle volume to slightly contract, there's going to be less cardiac output, and this is going to give you a smaller stroke volume. Less cardiac output, then is going to cause your blood pressure to drop slightly. When this is exaggerated and the drop is greater than 10 millimeters of mercury with inspiration, we're dealing with asthma and COPD, especially chronic bronchitis. I said to you there was a third. So the third would be a condition known as cardiac tamponade. Cardiac tamponade. So the three conditions I want you to remember as causes of pulsus paradoxus are one, asthma, two, chronic bronchitis, and three, cardiac tamponade. We talked about pursed lips breathing, breathing through lips that are pressed together. In this situation, what happens? The patient contracts his anterior abdominal muscles, which increases the intra-abdominal pressure, which pushes the diaphragm up, and this forces the air out of the distended alveoli, which lack elastic tissue to empty on their own. And this is classic for emphysema. Next is tactile fremitus. You're going to instruct the patient to say 99 every time you touch their chest. You're going to go through the same 10 areas. You're going to test their ability to follow instructions by touching them on their shoulder, and they should say 99. It's the same as your vocal resonance. So tactile fremitus is the same as your vocal resonance. So every time you feel me touch your chest at the back, say 99. And you follow the prescribed pattern 1 through to 10. And you're going to note the feel when the patient says 99. If it is increased, that's the same area you're likely to get bronchophony, the same area you're likely to get egophony. So if it's over in the apices, you think of TB. If it is over in one base, you think of pneumonia. So increased tactile fremitus is seen in pneumonia and TB when there's underlying lung consolidation. If it is decreased, there are two conditions that are likely to cause this. One is emphysema, and two is pleural effusion. Pleural effusion is easy to understand in that between the air entering your lungs and you saying 99, and that gets transmitted via your bronchi into your hand palpating. If you were to put fluid in between there, it is usually easy to understand. Fluid is going to dampen the amount of vibration coming through, and that will give you obviously decreased tactile fremitus. Replace the fluid by air. Excess air seen in either pneumothorax or emphysema is also going to cause a decrease in your tactile fremitus over the affected part of the lung. As I said, vocal resonance is where it's the vocal equivalent of tactile. Tactile is to feel, vocal is to resonate with the stethoscope. So transmitted voice sounds is vocal resonance. Instruct the patient again to say 99 every time you touch them with a stethoscope. You go through the same pattern, 1, 2, all the way down to 10, and you note the sound that resonates through the diaphragm of your stethoscope. Increase vocal resonance is indicative of pneumonia or tuberculosis. Decrease would be indicative of emphysema or a pleural effusion. Tracheal deviation, I'm not too sure how you We're taught to do this. This is what I was taught to do with my dominant hand. I'm right-handed. I'm putting my right index finger over the patient's right clavicle. I'm putting my ring finger over the left end of the clavicle, so over the sternoclavicular joint. My middle finger lies in the middle, and then I'm going to drop my finger in the middle, and I should be on the trachea. So index and ring finger over the sternoclavicular joints. Place the middle finger in the suprasternal notch, otherwise known as burn space. The trachea should be felt palpated directly under the tip of your middle finger. If not, it is displaced. Now, if you're not too sure you are on the trachea, run your middle finger up and down, and what you're going to feel is the anterior portions of your C-shaped tracheal rings or cartilages. Again, if you're not too sure, am I feeling the trachea? Ask the patient to swallow. And if the patient swallow, then the trachea would move up. It would move underneath the rings, would move underneath your middle finger. If when you do that, your middle finger is not slap bang on the trachea is off to one side or the other, then it means the trachea is displaced. The significance is different depending on whether this is a large effusion or tension pneumothorax, or whether this is tuberculosis. Tension pneumothorax and a large effusion will push the trachea away from the side of the pathology. You are going to get a question like this in the exam, where I give you a particular finding, and then I ask you for the interpretation of the finding. So tension pneumothorax and a large pleural effusion is going to push the trachea away from the side with the tension pneumothorax or the effusion. If the trachea is deviated to one side and the patient has on that side increased tactile fremitus, increased vocal resonance, and increased percussion note in the apex, then that is likely to be tuberculosis, in which the chronic scarring due to the chronic inflammation shrinks the lung, pulls the trachea over to the affected side. So one is pushed away from the side of the pathology, the other is pulled towards the side of the pathology. And then there is wheeze. Wheeze is defined as the continuous high-pitched musical sounds that are heard usually during expiration. It may have a whistling sound or a squeak depending on the pitch and the intensity. And this is caused by narrowing of the airways. This is seen classically in asthma. This is seen classically in chronic obstructive airway disease, chronic bronchitis, or it may be seen when the airway is partially obstructed in a patient who smokes, who has a localized wheeze somewhere in the middle of the chest, only on one side but not on the other side. You should put the two together and go shortness of breath, smoking, localized wheeze, maybe lung cancer. Lung cancer in the bronchopulmonary region. So this would be a bronchogenic carcinoma. And then opt to refer the patient for a chest x-ray screening for possible lung cancer. You're not going to wait until he presents with hemoptysis. You should not be waiting until he has lost 20 pounds and has no explanation. He's not been on a diet. He's not been exercising. He's just looking nice and fit, except he's a little tired. And then finally is whispered pectoriliquy. You ask the patient that every time I touch you with my stethoscope, I want you to whisper 99. And when the whispered 99 sounds like a normal 99, then a whispered pectoriliquy is present. The presence of whispered pectoriliquy is indicative of consolidation, which is seen in pneumonia, and localized atelectasis, which is seen in tuberculosis. Any questions? All right, next week we will be doing abdominal pain. Please read the chapter before, download the appropriate words, review it. As I said, 50 to 60% of all of the information we're covering, you guys have covered either in pathology, physiology, or in physical examination of the various systems, chest, abdomen. Any questions? If there are no questions, then if we have time, we can play another 20 question think aloud game for 5 bonus points. If we don't have time, well, we'll do this when time is available. Okay? Bye for now.